Good morning, everyone. This is Dr. Mike, and welcome to day 11 of how to make your medical exercise training practice referral ready. Now, day 11, we're going to talk about creating condition-specific protocols, condition-specific medical exercise training protocols for your practice. Now, we published our post-rehab and medical exercise protocols. We published them initially back in 1997. We've redone them in our new manual, our Advanced Medical Exercise Specialist Manual, and we will present these protocols in an upcoming on-site workshop here in Houston, June 28th and 29th, our Medical Exercise Specialist on-site workshop. So we have protocols already, but you will run into a situation where you'll have clients that may have multiple conditions or maybe a condition you've never dealt with before. With that being the case, you may have to put together a protocol. And please understand, everything in the field of medicine is based on protocols. Now, I'll give you an example. I read a book a few years ago called The Checklist Manifesto. It was written by a gentleman who was a surgical resident at Johns Hopkins University Hospital in Baltimore. Now, considered one of the best teaching hospitals and medical schools in the world. Well, one of the things he said was they had a problem with infections in the surgical ICU. Now, this is the surgical ICU unit at Johns Hopkins University Hospital. They were having a problem with infections. Well, what they did, they went back and they surveyed and they looked at all the procedures used by all the individuals that were going in and out of the surgical ICU. Physicians, residents, surgeons, nurses, respiratory therapists, everyone. And what they started to realize was everybody was going in and either putting on a surgical mask or a cap, or they may just simply put on the surgical gown, or they may just put on gloves, or a combination of those. And they realized what was happening. They needed a standardized process so that they could reduce the possibility of microbes being introduced into the surgical ICU. So they came up with a protocol or a procedure or a standardized guideline, or for some of you like me who've been in the military, a SOP, a standard operating procedure. So literally what the condition protocols are, it gives you a step-by-step process. It doesn't say you're handcuffed to it, you can't move. It says, here's the process, and we can manage this appropriately for the client. We can add a little here, add a little there, but for the most part, we're going to follow this protocol so nothing falls through the cracks and nothing goes wrong. So with that, that's what we're talking about today. Now, with that said, make sure we go over our scope of practice. We always are going to go over this. As a medical exercise professional, medical exercise specialist, you can provide MET assessments, cardiovascular flexibility, strength training. Mix those three together, you get functional conditioning, balance training, lifestyle education. Again, this is teaching the client how to live with their condition and how to exercise and maintain a level of wellness with their condition. You, the medical exercise professional, are ideally suited to do that, and that will become more important. Please remember, the doctor, the therapist, the chiropractor, the dietitian have told them all of these things when they go in for their office visit or when they leave the hospital. They are discharged from therapy. The client just simply forgets. Please reinforce those with your lifestyle education programs, aquatic training, and stabilization training. And that leads us now to, we also offer two manuals, our Cracking the Code manual, which is for those of you that want to seek insurance reimbursement. We are giving you everything we've learned in here in 31 years about managing medical conditions and getting reimbursed for them, utilizing exercise, and also our Advanced Medical Exercise Specialist Manual. Now, we bundle those two together in our digital offering or our digital editions for only $199. I would highly recommend you get those. And we will reference our Advanced Medical Exercise Specialist Workshop multiple times during this program. So you may want to get a copy of that. Again, we're talking about condition-specific protocols. And with these protocols, when you put them together, and we have a handout for you, and let me make sure I give you the link to download the handout here. You go into the chat. For those of you that are watching this at a later date, you will find the link down below the video. The session guide actually walks you step by step through the post-rehab protocol and also gives you a sample flow chart of one of our protocols. Let's talk about the components of the protocol. Every post-rehab or medical exercise or medical fitness protocol should have a criteria. The criteria being, what are the minimal requirements the client must meet to begin a medical exercise training program? Just because they call you, just because the doctor refers them, the therapist refers them, doesn't mean they're appropriate and ready. That was one of the major things we looked at when we started developing the protocol. We wanted to make sure that that client that may have been discharged 2 or 3 months ago, 2 or 3 years ago, didn't try to circumvent physical therapy or other health care by now going to the medical exercise professional. So the criteria basically says the client must meet these minimal standards, and these are all functional or medically based standards, such as do they have radiating pain? Is their pain level above a 7? Do they have full range of motion? You'll notice in the protocol we'll show you here in a few moments, we outline a criteria. The post-rehab assessments, what assessment procedures must be done for this particular client? Your post-rehab precautions. During the exercise program, what are precautions you must take? The phase progressions, how many phases are in this protocol for this particular condition, and also progression guidelines. You'll see that in just a few moments. Download the condition-specific protocol developmental worksheet. That's what we call it. Please download that. And you'll notice that with the protocol download, we're giving you 2 pages. The first page looks at the target condition and then ask you a series of questions. So this is specific for the condition you want to develop the protocol for. The second page is our total hip replacement protocol. We do note the criteria, the assessments, the precautions, the phases, and at the bottom, the progression guideline. When you put together your protocol, assess the client initially. Make sure you understand what their condition is and all the ramifications of their condition. Also, if you're putting together a new protocol, establish a criteria that says the client must meet these guidelines for them to be appropriate and safe for a medical exercise professional to work with. Then, what components of the assessment do we need to follow through on with this client? Such as with every client, we need to check blood pressure and heart rate. Every new client, we need to check strength, flexibility, range of motion, function. We do need to note their pain. But with that, do we need to do a functional assessment scale? What do we need to do? As we move the client through the program, what are the precautions we need to follow? What are the phase progressions? And also the progression guidelines. With the protocol, again, this is not handcuffing you. It is simply based on the idea of making sure nothing falls to the cracks. So our thought with the protocol is manage the condition and train the client. The protocol says, here's how we will manage this medical condition. But let's say the client has a total hip replacement as well as they're diabetic or hypertensive. And on top of that, the client only can come in once a week. So now you have to look at this a little differently. And instead of following the protocol that may call for twice a week, you only bring this client in once a week, but also this client is diabetic and or hypertensive. With that, I also need to make sure I fit those 2 parameters in the program. So I'm managing the primary condition, which the client was referred to you because of the total hip replacement, but I'm training the client, making sure I accommodate. They're only able to come 1 day a week, which means I give them homework to do. And along with that, they also have diabetes and hypertension. So manage the primary condition utilizing the protocol. And any other issues the client has, comorbidities, you're going to train the client by making sure you take into account the safety guidelines and the appropriate management guidelines for those conditions too. Here's a copy of our protocol. Okay, this is just the flow chart. Our protocols usually are anywhere from 5 to maybe 9 pages. And with the flow chart, which is the last page of each one of our protocols, it walks you step by step through the process. Now, this is simply an algorithmic flow chart. That's all it is. You start here with the post-rehab protocol, and this is for the total hip replacement. The client is referred to physical therapy initially. Then they're referred for post-rehab training or medical exercise training. We have a post-rehab criteria. So notice what it says is, doesn't meet the criteria, refer back to the MD. So we obtain a medical clearance. We make sure the client meets the post-rehab criteria, but notice this line goes up and back. If they don't meet all the items in this criteria, we're sending them back to the doctor. So we have to make sure we include a post-rehab criteria. So notice with this one, no open wounds. It's a surgical procedure. Full weight bearing. They should be able to fully weight bear by the time they get to you. They have minimal pain, 4 or less on a 1 to 10 scale. They've been DC from physical therapy. They have a medical clearance, and they're at least 12 weeks post-operative. Folks, if you work with this client in earlier stages, or they still have an open wound, or they're unable to fully weight bear, by the time they should get to you, at least 12 weeks out, they should be past this. Now, the world has changed. We're finding now that they may only be 6 or 8 weeks out. Okay, timetable changes, but do they meet the other criteria? And with that timetable changes, they're there a little earlier, you do need to make sure you get a referral from the physician. Notice here we have a post-rehab assessment. Notice in the assessment, we talk about the medical history, screening, balance assessment, check their active hip range of motion. Can they do a lateral step up? What kind of strength levels do they have for the leg press, leg extension, hamstring, also the quad? Also, what kind of strength do they have with hip AB and adduction? And do we need to do any manual muscle testing of the hip, looking at gluteus maximus, gluteus medius, and also the Harris hip scale, which is the functional scale that we use for assessing clients' function when they have a hip condition. Now, notice it says here we have precautions. Notice one of the precautions: avoid combined flexion greater than 90, adduction across midline, and internal rotation. Second one, excessive hip movement into hip flexion, adduction, or internal rotation and adduction. And then lastly, avoid sitting on low chairs or low seats. Those are our precautions. Next, now we get into the phases. Phase 1 works on strength, weeks 1 through 2. Phase 2, strength again, weeks 3 through 4. Phase 3 looks at functional strength, weeks 5 through 8. And then phase 4, weeks 7 through 8, functional conditioning. Now, notice with these exercises, and folks, you can mix and match the exercises any way you want for the criteria you develop. Now, notice with this, we have a number of exercises. We're not expecting you to do all these exercises every time the client comes in. You mix and match based on if you're working with the client at home, in a gym setting, in your studio setting, or what specifically they need. And you may find for some of these activities we know in phase 1, the client has progressed beyond them. So you select from this group of exercises. They go from the low-level functioning client to the high-level functioning client. But what we do is we do a phased progression. So phase 1, we're looking at strength. Okay. Now, phase 2 here continues on looking at strength. And notice what it says here in phase 2. We continue with phase 1 with increased intensity, but now look what we're doing. We're adding wall squats, leg extensions, and they don't have to be with a machine. You could do the leg extensions or quad strengthening any way you want. Now, notice we have a number of machines that are noted here. Some people say, well, Dr. Mike, I don't like using machines. Folks, it's not about the machine. It's about the muscle group you're targeting. Let me say that again. It's not about the machine. It's about the muscle group you're targeting. Here's what a protocol basically says. The client has shown functional deficits after their surgery, the onset of their condition, or with the disease process they have. What areas are they limited in function? With those limitations in functions or their residual functional deficits, now we say, what do we need to do in those areas? Do we need to improve strength, flexibility, stability, whatever the case is? And what muscle groups or joints are we targeting? Please write that down. It's not about the exercise. It's about the muscle group or the joint or the activity the exercise is targeting. So is the exercise designed to improve flexibility, strength, endurance, stability, coordination, balance, whatever the case is? So this progression guideline with regard to the phase progression, phase 1, strength. Phase 2, we go farther into strength. Phase 3, we look at functional strength. And phase 4, we look at functional conditioning. Now, beyond this would just simply be human performance. If we had a phase 5, where they're completely, fully functional, and now they want to go back and maybe play tennis or pickleball. I've had tons of total hips and total knee replacements that went past our protocols for medical exercise training or even for physical therapy. They now were looking at human performance, being able to go back and participate in athletics or recreational activities. So you'll notice here when we get to phase 3, functional conditioning, weeks 5 through 8, the activities become even more intense. We increase the intensity of phase 2 activities, and now we're doing unilateral wall squats, lateral step-ups, and we're watching for signs of patellofemoral syndrome, because if they've had a hip replacement, I guarantee you they probably have quad weakness, because they've had that hip issue probably for years, unless it was a hip fracture. If it was an arthritic hip, I guarantee you that quad atrophy because they didn't want to put a lot of weight on it, on that leg. Phase 4, functional conditioning. We continue with phase 3 activities. We're doing more lateral step-ups with handheld weights now, mini squats with a Swiss ball, circuit training, and we perform the Harris hip scale, which is our functional assessment scale that gives us a snapshot of the client's functional capability. We do that every 4 weeks. Now, notice here at the bottom, we talk about progression guidelines. Every session must include hip abduction exercise. Folks, the studies were done years ago by a doctor by the name of Jacqueline Perry at Ranchos Los Amigos Hospital, a rehab center out in California. We found the most essential muscle to strengthen after a total hip replacement is the gluteus medius or the hip abductor. Next thing you'll notice, gluteus maximus is very important to gait. Yes, vitally important because it actually helps absorb the force when we go into heel strike, and it actually controls and helps with stability. Next, begin leg press with 1/4 to half of the client's body weight. Folks, if they're stepping up on a step and they weigh 150 pounds, when they step up on that step, they're lifting 150 pounds. So let's make sure they're able to do at least 1/4 to a half of that, and we should be able to progress them, if all goes well, to being able to do their body weight with the leg press. The ultimate goal is the unilateral leg press with the equivalent of their body weight. And then lastly, discomfort. The next day determines if the exercise program or is too intense. So if they're having significant soreness and discomfort in the muscles the next day, we went too far. We will have some discomfort, but if they're talking about 8, 9, or 10 on a 1 to 10 scale, maybe we did too much. But also remember, a lot of these clients have not exercised in years. So if they're having joint pain, and I've had clients say, Dr. Mike, my leg is really killing me after doing those exercises yesterday, and they point to their quad. Okay, that's quadricep discomfort from strengthening. Great. But if they're pointing to their knee or their hip or their ankle, they're pointing to a joint, that now tells me, did we put too much stress in the joint? So you have to remember the joint itself also is being compressed or exposed to force when we're doing exercise. So we want the muscle to absorb most of the force, but the joint is too. And sometimes we have to remember the joint structures, the ligaments, the tendons that are passing through the joint. The joint surfaces may be damaged, or the surgical hardware is there and maybe it's not ready to absorb that amount of force yet because we need to strengthen the muscles more. This is a rough idea of the protocol. Take a look at your handout, and you'll notice there on your handout, we talk about on page 1, the target condition. Note the condition name. Next, the client population or the referral source, or what referral source. Maybe you have a doctor who refers clients with total hip replacements on a regular basis. And what is the common functional deficit you're seeing in these clients? Now, this protocol isn't just for one client, it's for multiple clients with the same condition. Phase 1, we look at strength, stability, and mobility. What are the goals you want for the phase 1 portion of your protocol? What's the exercise focus? And what is the criteria to advance the client to phase 2? In phase 2, we look at functional strength and stability now. So we've gone beyond strength, stability, and mobility. We're now looking at functional strength and stability. What are the goals here? What do you want the client to be able to do based on their condition? What is the exercise focus? What are we focusing on? And then what's the criteria to move them on to phase 3? So literally the protocol says, what are the goals? What are we focusing on? And what's the criteria to move on to the next level? Phase 3, functional conditioning, which is next. What are the goals? What's the exercise focus or exercises to focus on? And it could be more than one exercise. And also the criteria to advance to phase 4. Now, phase 4 is the highest phase. We haven't included phase 4 on the protocol we have here on the screen, the way we've done it here in your handout. We gave you a phase 4 here in the handout, that's human performance. What do you need to do to have the client be able to perform beyond medical exercise training, post-rehab training, or functional conditioning? What do they need to do to go back to the highest level of their recreational or work-related activities? So human performance isn't talking about what they're doing in the gym setting or the exercise setting. It's getting them ready to do activities at the highest level outside of your facility in a sports-related environment, a recreational environment, or work-related environment. Notice again, we're looking at goals, exercise focus, and a criteria for discharge or maintenance. So at what point does the client max out on the protocol? And now we're going to move them on to discharge, or maybe we're going to step them down to personal training. So we move them out of medical exercise training, or we're going to move them into a maintenance program where they're able to do some of this on their own. So the idea when we started medical exercise training was medical exercise training was the highest level of individual supervised fitness and exercise. So you may charge $100, $150 for that. But at some point, the client reaches a plateau or they've maxed out, and now we need to move them down or step them down to a level where they're now able to maintain their level of function, or they've reached the max. maintain their level of function, or they can do it in a maintenance program. And that's something we need to start thinking about as medical exercise professionals as we move forward over the next 2 decades, because as insurance carriers start reimbursing for this, at some point they're going to say, all right, they've reached their maximal level or they've plateaued. We want to keep them there. We're going to step them down. What is the step down criteria, or move them to a functional maintenance program? You'll also notice at the bottom of the document here, it gives you a place to note assessment and progress notes. So what are the functional outcome measures, strength, range of motion, balance, that you're going to use as the benchmarks as to if the client is getting better, and also the progress intervals? At what point are you going to note the progress or reassess their progress utilizing functional outcome measures? What will be the intervals? What will you look at? And then you're going to report that to their doctor, therapist, chiropractor, or to the client, or if there's an insurance carrier involved, to the insurance carrier. All of these protocols we have available in our medical exercise protocol manual, which is part of our advanced medical exercise specialist manual. All of our protocols are in here. They start on page like 579 and go up to page 1083. I didn't know we had that many pages of protocols, but it's step-by-step medical exercise and post-rehab protocols for 62 different medical conditions. We also go over these protocols in an upcoming workshop we're going to have here in Houston, June 28th and 29th. Here in Houston. It's our on-site workshop. It's a 2-day workshop. If you're interested in that, email me at drmike@postrehab.com. And all of this is sponsored by our Medical Exercise Specialist Network. We are relaunching our network at the end of June. Please look out for the emails that you may get about that. And with that, this is all part of our Cracking the Code webinars. We try to do these every Friday, but we're now in the midst of a 30-day challenge. So thank you for joining us for the day 11 of the 30-day challenge. The recording for this will go up later on today. And I've neglected to say, and I wanted to say it at the end, Happy Memorial Day to everyone. To all of you out there who have loved ones that have given the full measure for our nation, we thank you, and we thank you for their service and their dedication. Folks, I had the great honor of being a United States Army officer. When I got out of the Army, I was an Army major. I was lucky enough, I served with a paratrooper unit. I went to the 82nd Airborne as well as the 75th Rangers. I went to Ranger School and Airborne School. The Army paid for me to go to Howard University, and it was indeed an honor and a privilege to serve as a United States Army officer with the men and women I served with. So to all of you that have stood the post, and if you're a loved one who supported someone that did that, thank you. I served 7 years. It was the greatest adventure I ever had. To all of you, happy Memorial Day. We will see you on Wednesday for day 12. And don't forget, on Thursday, I think that'll be May 29th, we're going to have an evening session. We're going to go over everything we've taught days 1 through 12. Wednesday will be day 12. And then Thursday evening, we're going to do this get together through our MES Masters program, where we're going to present everything we've done through days 1 through 12. So thank you for joining us. Happy Memorial Day and all the best. We'll see you next time.